And the big emphasis of this, which I think John Shin will agree with, is that it has to always be a multidisciplinary approach. So my first case is going to be hopefully proving that point. All right. Now, Koi Tan, do you want to take this case?
Here is an MRI of a patient. On the very far left, we have T2 sagittal sequence, and right away we can see, a lesion involving C7, probably essentially a vertebral plane of T1, and some involvement of T2 as well. And on the central panel, it's pretty homogeneously contrast enhancing, suspicious for pathologic tissue. And on the axial sequences you've shown, we see fair amount of spinal cord compression.
A fair amount. Is that, if you're a radiologist, is that what you would dictate, a fair amount?
Severe.
Okay, thank you. I'm just giving you a hard time. Now, okay, so Koi Tan just destroyed my whole point here because he did such a good job with the case. I'm very impressed with that. So yeah, so this, like you said, it's a sagittal T2 here and a sagittal post-contrast fat-saturated image. And I'm just going to be doing this, say a little bit about the imaging for those of you who don't know a lot about like the details of the MRI. A lot of you do, but when we do these post-contrast fat-saturated images, we do them because normal bone marrow is almost entirely fat, and fat is bright on T1, so sometimes it's hard to see the enhancement with the normal marrow signal. So we take out all the fat signal, so the enhancement is very avid. So that's just a little radiology pearl for that. Now, what Koi just said, I'm amazed that he got this. So indeed, there are 3 levels involved here, and most people would have missed that. So C7, and you can see, you can count by the spinous processes. So here's 2, 3, 4, 5, 6, 7, and 1 is a vertebral plana, as he just said, and then 2. So we first talk about the levels that are involved. Then we talk about the alignment. So when we're talking about spinal stability, does this person need to go to surgery? Do they have still preserved alignment? Do they have frank subluxation or translation, which means they're very unstable? Do they have a new kyphosis, which this almost looks like? So we would put that in our report as well. Now, as he said, there's epidural extension of disease going into the canal, compressing the cord. Huge prevertebral component as well. Here on the axial, T2, I think that's a T2. Here's the post. You can see this is the huge prevertebral component. Here's the esophagus. Here's the trachea. This looks a little bit like some of the cases John Shin showed a little while ago. And you can see the difficulty you're going to have dealing with this case just because of the surrounding structures involved. So that's what we need to do first. We want to talk about where it is, what's involved, and what is it doing. Then the next step is narrowing down our differential. So when we were on a couple weeks ago, John Shin and I said, you always have to get CT when you're doing bone lesions. So here's the CT, and maybe this might help you with what kind of tumor this is. Maybe not. If anybody wants to take this, or else I can. No? Okay. So we see that it is definitely a lytic tumor. We see on this axial that, it's not permeative. It doesn't look aggressive like lymphoma or renal cell or anything like that. It has these thickened struts, which are seen with tumors that are more indolent and are slower growing. This almost has a mini brain appearance. If this is a radiology term, I don't know if any of you in neurosurgery know that, but that kind of gives away what this is. But I won't say it yet because I want to know how you guys would approach this in terms of management first, before I tell you what I think it is, because that gives it away. So John, what do you think?
Wendy, actually I have a question, and I think that this may be just a very basic educational point, but I was just wondering, as a radiologist, what's your specific workflow in terms of when you look at like that MRI, do you have a methodology for looking at the bone versus the cord versus the epidural space, and then all that other stuff like the esophagus and trachea? Because I think for most neurosurgeons, orthopedic surgeons, we're not like really looking for the trachea or the esophagus or where the carotid is, or lymph nodes or things like that. And when you look at a radiology textbook, they've got nice color captions for where everything is. And I think that it may be helpful, like maybe shed some light on like how you approach it, maybe, in terms of, we can see what's obviously there, but do you have a like kind of workflow?
Well, so whenever I'm looking at cases like tumor cases, and hopefully I'm answering your question here. So look at the bones first, like I said, alignment, what's involved. Is it going into the canal? So the bones are first, the alignment is first, the canal is second. What's it doing to the cord? Is it compressing the cord? Cord signal is third. I obviously don't have all the series and all the images up here just because there's not enough room. And this was just a quick preview case. But so epidural disease, compression of the cord, intrinsic cord signal. Then you go to the soft tissue. So we see it's coming out into the prevertebral space. I don't know if I'm answering your question. You kind of have to know what the, you have to maybe be a radiologist, I don't know, or listen to your radiologist to know that your esophagus lives right here. And this is the signal of an esophagus on T2 and on post-contrast, enhancing mucosa of the esophagus. And then the characteristic shape of the trachea. And you can see probably thyroid gland around it. And then we'd also, on this and on CT, look at the vessels as well, which are nearby. And that you can actually see on my next slide as well. This CT is actually post-contrast. And you can see the enhancing vessels, the enhancing thyroid gland, in addition to the tumor and the trachea, less well the esophagus. Does that kind of answer your question a little bit, or?
Yeah, no, absolutely. I think that's I think that's very helpful, just because I think, you know, where you're pointing to right there, around the trachea in front of the spine, I think that's sort of no man's land. You know, I think that we're not so used to looking at that. But so let's see, any takers on what we think the underlying pathology is here? I think that's what you were getting to before, right, Wendy?
So, yeah, so I'll just, while you're thinking there for a second, so that's my job, is I got this tumor first. The patient came in with symptoms. I got it. I told you what levels are involved. I told you what it's doing to the canal and to the cord. It's compressing the cord. There was no cord signal. On here, I'm showing you the osseous characteristics, and I'm going to give you a differential, but we're not going to do that yet. Radiology's second job, my job, this came to me for biopsy, so I could give you tissue before we take this to tumor board and proceed with the decision. I was kind of hoping that Dr. Coitian would say, take this to surgery and give us his surgical approach, but he's probably too smart for that. So I don't know if you want to say, John, or do you want me to keep going? Do you want to say anything about management and what you would do here? Because radiologists don't know before the biopsy maybe what it's going to be. We have an idea.
Well, let's hold up for a second.
Yeah.
I mean, I think that
case, we're never going to get to the rest, but go on. Yeah.
No, I think that you know, you've presented a patient with severe cord compression, kyphotic deformity.
Yes, he's going
you
to
know,
say.
I think that you know, unless this patient is like completely neurologically intact, which I would have trouble believing, you know, to me, this patient is getting rushed to surgery.
Perfect. Thank you, Coy. That's the wrong answer. That's what I wanted you to say. Okay, so we're going on here. And then I'll tell you the pathology in a minute. So this is over here. This is pre-treatment. This is post-treatment. Radiation therapy only. This was a plasmacytoma.
Yeah.
No surgery. Look at this is amazing. All this cord compression, this is the axial epidural extension of disease compressing the cord. So maybe, I don't know, maybe Coy's right. If they were really severe, you probably stopped taking surgery, but they got radiation. And look at the open canal. Look, you got CSF around there now. Amazing to me. I couldn't believe this result. So you have all this epidural extension, all that shrunk down, the prevertebral part too. This again is pre, this is post. Look at this post result. You've got an open canal now just from radiation, no surgery.
Well, Wendy, that doesn't belie the fact that there's now no bone providing anterior column support.
You're right. And so maybe my point was that multidisciplinary approach. So I got the images, I did the biopsy, we talked about it in tumor board, and the decision was not surgery, but radiation. So that was kind of my little trick case. We ended up taking most of the time on my one introduction case, but we'll go on now. So like I said, my point was it's a multidisciplinary approach. It's not always surgery. All right, so this case, I've already kind of described to you what tumors look like. This was just kind of the classic appearance of Mets on MRI, and I just wanted to go through it quickly. Sagittal T1, it's T1 hypointense. This was a 56-year-old woman who came into ER, county ER one night. Only history we got was back pain. My fellow said, you know, do you want us to call, see what else is going on? I said, no, there's only one thing this can be, and that's metastatic disease. So T1 infiltration, pathologic fracture. We get a sagittal T2 to tell us what it's doing to the canal. So we can see the narrowing here of the canal and the fecal sac. This is our fat saturated T2 or STIR image, which is edema, only edema, and that shows tumor cells and fluid, so it highlights the metastatic disease. And again, as I explained, we get post-contrast imaging, but with fat saturation to highlight the enhancement, both in the body, not as much in the body as you would expect, in the body and the epidural space. And here, down here on the axial post-fat sat, you can see epidural extension disease and paraspinous disease. Now, this is the way that this is the talk that I've been giving for a few years in the SNR. We're trying to report these in a new way to be helpful to you as surgeons and to the multidisciplinary team. So in that case I just showed you came into the ER, this was my fellow's report, and it's fine. They gave this 2-page report, great description, everything going on, suspected metastatic disease, pathologic fracture, all this, which is good. But I deleted that and I put in my own. And so this is the way that I'm trying to teach people now to report in radiology. Point number 1, unstable spine, SIN score of 13. And that's what I'm going to explain in this presentation today in our cases, what the SIN score is. Recommend prompt surgical consultation. So it doesn't matter when people see the report, it doesn't matter if you're the ER doc or you're the intern on your first day or you're the person working in the cafeteria, you know exactly what the severity of this case is and what you need to do. So surgical consultation immediately. And you can see how that would improve patient care. Number 2 point, lytic metastasis L1, pathologic fracture with retropulsion, greater than 50% height loss. Each of these is a component of the SIN score, which I always tell our radiologists that you as surgeons know immediately what I'm saying. Without even seeing the images, you know what each of these mean and what it implies for your patient before you even see the images. Same thing with number 3, high-grade cord or conus compression, epidural spinal cord compression grade 2. So you don't even need to see the images. When you hear that from somebody in New York calling to tell you that, you know what's going on. I find that helpful. John Shin has told me that's helpful. I'd be curious at this point to know how many of you, John Coy, do you use the SIN score epidural spinal cord compression scale? And anybody in the audience, if you could type it in the chat box too, if you use that, or if you've heard that. And you'll have to tell me because I can't see the chat box.
Do you mind if I ask a question as well? The epidural spinal cord compression scale is very common. SINS is very common. It's not very common to see that in a report, so that's really outstanding that if we actually see that as part of the report as well. We also use the NOMS criteria. I know Dr. Bilski was very instrumental in developing that over at Memorial Sloan Kettering. Just a question for you. In this report on the right, it says unstable spine SIN score 13. If we're going to, without getting into the nitty-gritty details of the SINs, but the patient you presented before would probably, without knowing much more else, would probably fit that criteria as well too, as being an unstable spine. So you wonder about some potentially medical legal implications of seeing an unstable spine in a patient who was treated with radiation therapy, right?
No, I don't understand your question.
The patient didn't undergo surgery apparently, right?
Right.
So
first, yes. But I would have argued that actually was not a high SIN score. That was not unstable. What do you think, John Shin?
I think that, I don't know, are we saying that the SIN score was high with that first patient?
I don't think it would be. Maybe it would. Okay, it's lytic and in both. Well, maybe it would, but
I think so. I think it'd be very, very high without actually going through the details.
Right. I think the one qualifier here is that I think SINS is very useful, not only in a training environment for students, residents, and fellows, but also just in practice. It was developed by a collaborative group. It's been validated in a certain number of different ways, but not every scoring system has its flaws and limitations, and I think that the one area where there is probably the greatest potential for modification of the SIN score is likely in the cervical spine, particularly craniocervical junction, as well as cervical thoracic junction. Because some of the criteria and the point sort of distribution for SINs, you'll notice that even in this, it'd be interesting to take a look at what that is. You could have someone with horrendous anterior column disruption and no posterolateral involvement, and that SIN score still could come out to low to intermediate, you know, and I think that that's the only qualifier that I would throw out there for this discussion, is that, you know, you just have to keep in mind in the cervical spine, there is a little bit of a debate in terms of the reliability and sort of consistency with really extrapolating that. So I wouldn't necessarily use it as like, because SINS is more than 12, it has to have surgery. I mean, I think that is a consideration. I don't know if that helps clarify it a little bit.
And also there are two different points here that I was going to make later, but I'll make now. One is I use this for two different things. This is an ER case, this second case, ER case, and I'm triaging. I'm making sure this person gets to surgery first rather than, you know, going home with their family doctor, going to their oncologist. I'm using SINs and saying it's unstable so they will get the care they need immediately. Even in tumor board, using the SIN score, it isn't cut and dry, you have to do this if it's unstable. That's just kind of part of the equation of how we take care of people using, as you just said, Jonathan, the NOMS criteria, which is at the end of my talk, and I bet we're not going to get to it today. But that's just one component of the decision-making that goes into how these people are treated. And again, treated by different specialties. They will be treated by radiation oncology and surgery and who knows, you know, who else. Probably a lot of different groups will treat one patient. So I would say in terms of medical legal, that's kind of moot, I think, in this particular case, at least from my perspective and from my reports. So is that okay? Should I go on, or do you have anything else? Okay, I'm going on. No,
yeah,
go
actually,
ahead.
there was one question in the chat box, Wendy, that I think is a really good point. You know, because SINS for the most part is a radiographic evaluation, with the exception of the characterization of pain, you know?
Yes.
And I'm just wondering, and I think that some of the people here have commented, you know, like, how are you calculating that considering what's in the chart, or are you leaving it as a base score without the clinical factor, or how are you dealing with that?
I'm skipping ahead now because you're making me skip ahead.
Sorry.
All right, then I'll go back to my other cool case. So yes, so when we're calculating the SIN score, and I'll just skip to this part. So there are 6 questions to be answered, and radiologists often talk about these things anyway, but they don't in an organized fashion. And so this is what we've created, or I guess I made this, created based on the actual SIN score from the literature. I've made this to simplify it. We have 6 questions we're answering for a metastasis in the spine. Where is it? Is it in the junctional spine, mobile spine, semi-rigid spine, or rigid spine? I'll show you examples of these. I just want to show you this chart. What's the quality? Is it lytic, mixed, or blastic? What is the alignment? Is there already frank subluxation, kyphosis, or scoliosis, or is it preserved? How much collapse is there? Posterior element involvement, bilateral, unilateral, or none, and mechanical back pain, as you just said, John. So 6 parts of SINS, and 5 are from the imaging, and 5 go into our reports. That 6th part, which is mechanical back pain, not cancer pain, which is worse at night and gets better during the day. This is actual mechanical back pain, which is worse when you're walking around with axial loading, like degenerative back pain. That we may know from the ordering doctor. We may know it from the EMR, in which case we can put in a score. If not, then we can just give our score without that component, and it can still be used in tumor board, and whoever knows that component can put it in. So the SIN score itself, for those who don't know, for each of these questions, depending on what your answer is, you get a number of points, and you add up those points, and depending on what they are, you get a categorization, and you can give your recommendation. So 13 points, 13, 18, unstable spine, urgent surgical consultation. 7 to 12 is that indeterminate area, but still probably a good idea to have them see surgery first. 0 to 6 is stable. So that means they don't need to go to surgery consultation at all. They can go to their oncologist and get worked up for their treatment plan without worrying about spinal instability. Now, if it's okay, I'll go on and just show examples now that I've told that, unless anybody else has a question first. Okay, let me go on. So those 6 questions that we're answering, I'm going to give you pictures of each to show you why they're important. So where the metastasis is in the spine makes a difference. Some areas are much more devastating when there's spinal mechanical failure than others. So at the cervical occipital junction, cervical thoracic, thoracolumbar, and lumbosacral junction. And you all can speak much more eloquently to this than I can. But those areas when you have spine failure, you're going to have some severe consequences to your spinal cord. Other areas, so that gets the highest number of points in the SIN score. Other areas, like the rigid sacrum S2 through S5, you can have failure and it's not going to give you cord compression, pain, or paralysis or death. So this first case over here, an axial and a sagittal CTA, this is renal cell carcinoma. You can see this metastasis is completely replacing and destroying the posterior elements here on the right. It's displacing the vertebral artery anteriorly right here. Here on the sagittal, you can see there's no bone left that's holding the head on the cervical spine, so the head's gonna fall off. So this is a devastating place to have a metastasis. Very difficult for you to treat, and I'll ask you about this in a second. Now contrast this with this melanoma metastasis in the sacrum. Whole sacral ala is involved here on the left. This is a axial T1 weighted image. T1 hypointense, like I told you metastasis look like. This is a CT. You can see it's infiltrating the S1 foramen. It's probably compressing that S1 nerve. Now, as big and bad as that is, it's not going to be devastating to the patient in the sacrum as it would be in the cervical spine. Now, in the middle here, you've got the mobile spine, you've got cervical and lumbar. So that's the second highest number of points. Thoracic is less points because you've got the ribs and the sternum stabilizing the spine. So even if you have collapse of one of these thoracic bodies, you've still got some extra stabilization that will help you out and keep that from being quite as devastating. Now, I posted this first case right here, this renal cell case on Twitter, and I promised people that we could talk about it. If anybody briefly wants to say anything about that case and how you would manage that, or I can go on, either one. And like I said, I can't see the chat box, so let me know if anybody is saying anything about these or offering any suggestions.
Yeah, what do people think in the chat box, and any ideas? I mean, this is clearly a radio-resistant tumor, renal cell hypervascular, it's, you know, kind of upper cervical spine, but it does involve sort of the C1, C2, well, actually C2, C3 there. Pretty diffuse epidural disease. And this patient has mechanical pain. Any other considerations? Anyone thinking here of surgery versus radiation?
I think the first thing that I always ask with cancer patients is, you know, what's their extent of disease and what's their general prognosis considered to be? Because, you know, this looks pretty bad, but, you know, if their prognosis is years versus days, my management's going to be much, much different.
No, that's a great point. And I have some slides actually at the end that I'm going to kind of go into that just a little bit as well. That's a great point. So let's say this patient has decent survival based on whatever you use. We're going to launch into that a little bit later too, but someone here, Mike Selby's talking about Tokahashi. Someone else talked about Tokahashi. JBC's talking about the Sorg nomogram, which we developed in Boston, other things, frailty scores. So let's say based on whatever score you like, whether you created it or your brother made it up, you know, pick one, go with it, and you've assessed that. So you've done the N part of NOMS, the O part you get mechanical stability, we figured out, and the S part, like I said, we'll talk about that a little later, but you've determined by your criteria that patient's good to go. So what do we think here? JR, what do you think about surgical strategy for this? What's your thought?
Yeah, so assuming the patient's a good surgical candidate, taking into account, you know, frailty scores, KPS, the patient has a good oncologic prognosis, and assuming that this tumor is not responsive or radio resistant, chemotherapy resistant, and you ultimately decide for surgery. The main things here are that if you look at, there's essentially complete erosion of 2-3 facets posteriorly. There's erosion, I can't see, I think in the axials maybe even at C1. Is that it involves the vert on the right? Is that?
Yeah, sorry,
yeah.
that's, yeah, I don't have more pictures, sorry.
Yeah, it's not C1,
Yeah.
I mean, it's a subaxial spine, but yeah, you can see that it basically completely encases the vert on the right. And I'm assuming that if you were to get additional imaging, potentially upright x-rays, you would see some degree of kyphosis or something that's suggestive of instability. Again, looking at the SIN score, without going through each one of those points, this is almost certainly will be something that will be potentially unstable and require surgery. So going back to what you said before, in terms of your surgical strategies, a patient like this with so much destruction of 2 and 3, you're probably going to have to do something essentially either at C1, you're probably going to need some fixation points above and below that. So the question is whether or not you would go to occiput to just below that. So what is that? 4, 5, 6, somewhere around there. Occiput this to 4 or 5, occiput to 6. Again, knowing in mind of the morbidity of fusing to occiput, but I don't think you stop at C1, especially with all that tumor involvement at 2 and 3. You're going to have a stable construct. So occiput to pick some level below the tumor there.
Yeah.
Yeah, those are great points. Coy, what do you think?
Yeah, I largely agree with Jonathan here. So I think the goals of surgery here are, decompression of cord and stabilization. So, decompression of any stenotic levels at, based on your MRI, kind of removal of as much tumor as is safe.
Yeah.
And then, stabilization and fusion, I'd do, occiput to C5 or so. Who would be more aggressive with the tumor?
How much more aggressive could you be?
Yeah, I agree. I mean, I think these are tough. I think these are tough cases because I think I'm seeing a lot of chat in the chat box, people saying, get an angiogram, embolize.
This
is angio, yeah.
Yeah, possible balloon occlusion, all these things. And I think that's great. I think the thing to keep in mind, I mean, I think these high cervical cases, even with embolization and even occlusion of the vert, you still get a lot of bleeding, not only from just the tumor itself, but all these deep muscular branches that form all these collaterals. So that's the one thing I'll tell you from my own experience, that you still get a lot of bleeding, and to be prepared for that. The other thing too is, especially there on that axial that Wendy's showing on the left, that where that vert courses, it's very difficult to identify and get control of proximally and distally. If you want to get distal control of that vert lateral to the C1 lateral mass, you've got to really dissect that open. And by the time you get down there, you will already have lost a lot of blood. So just think about a case where you're doing a C1, C2 fusion for like an odontoid fracture or trauma, and how much it could potentially bleed with that dissection. Here, you're just going to be going through so much tumor to get down there. So I think that is a real concern operatively. So it's not a case that, you'd want to start late at night or even in the afternoon, and I think it's one of those things where you have to be very frank with the patient that, these are cases that you may just end up aborting. So I think that, it's one, I generally place all my instrumentation first after exposing, and with the thought of that, if something really happens, you lose a lot of blood, signals change, you can at least lock in the rod and close and maybe get that patient to radiation if surgical resection is really not feasible. And that's the only thing that I would mention here. And certainly we could go into the chat box, but I think you just have to be prepared for all these potential disasters that can happen with these renal cell hypervascular cases.
John, for if you were deciding, maybe not this case, but if you were going to do preoperative embolization, how long do you wait until embolization, and then when you take that patient for surgery? Like what's that gap? I know some people take them straight from embo to surgery. Some people wait a day or so, like as in the next day. And I've seen some attendings wait a couple of days, and I would probably, my own personal bias is not to do that, but I'm just curious what you tend to do.
Yeah, I think that's a really tough question. I think it's a great research question because it's very clinically applicable, right? I know that Dan Schubert recently, I think they published a paper in JNS Spine, I think just really within the last month or two, looking at embolization.
You looking it up?
Hold on a second, my computer just.
Okay,
sorry.
I'll start talking while are you?
Oh wait, no, sorry about that. Are you guys, can you hear me?
Yeah.
It's weird, my computer just had a seizure. But no, I was just saying that, I think that really varies because, I mean, Wende may know this actually better than me, but I think at least from my understanding, in the literature with regards to embolization, things have really changed because of the particles used. So people have used alcohol versus onyx versus coils and different things. And so I think that, just like a lot of spine literature, there's a lot of heterogeneity in, what's been used to use as embolic material. But I think that in general, we get the embo the day before and do the operation the next day. There have been some situations where I've done it the same day, but I typically don't like to wait more than a day. And the state of affairs in literature, it's pretty poor. So you're going to find things where things were done within a day. Sometimes in the literature, you'll see things up to 5 days, which doesn't really make much sense because most of these vessels will recanalize in some way, form collaterals in that time too.
Yeah, that's an interesting question. So, all right, so I'm going to go on if that's okay. So what I'm going to do, this is the great thing. So we just had ASNR and we gave our talks and they were pre-recorded, so nobody could stop us. But the great thing about virtual spine is we're all discussing these cases. So this is not going to go as planned. So I'm actually going to go backwards. There's no way we're getting through this whole little presentation. But maybe we can another day. Since we're talking about cervical spine, I want to show you guys this case because you're talking about the difficulties of cervical spine. This is a case I also showed on Twitter maybe a couple weeks ago, actually. This was important both for the imaging characteristics because you could tell what the tumor type was from these top two images, actually. But then I'd also be curious to see how you would manage it because the way it was managed in the place where I saw it, which I won't say, I was surprised by the decisions. So sagittal T1 pre, sagittal, can you see this with the, I don't know, my pictures are overlying it, so I can't see it as well. Sagittal T1 post-contrast, fat saturated image. And then we've got our sagittal and our axial CT. So I don't know if someone wants to take, maybe I'll just, for the interest of time, I'll take it. So on the sagittal T1, we've got the C2 vertebral body here expanded by tumor. You can see on this T1, this is normal bone marrow. It's kind of a weird sequence because it looks like everything else, but this is bright on T1 before contrast. This is our T1 post contrast. It's the same color. It's still bright. It's enhancing. And you can see this is post because you've got epidural extension of disease that's enhancing. You also know it's post because you've got mucosa that's enhancing here in the oropharynx, nasopharynx. You've got little blood vessels that are enhancing. Down here on the CT, you can see it's lytic, expansile. Here on the axial, you can see that it's involving the body itself. It's not going into the posterior elements. There's a little bit of epidural extension of disease. So if anybody knows what this is from this imaging, say it now. I won't drag it out. It's bright on pre T1. Anybody? Anybody? There's only one thing that does that. That's melanoma. So just like in the brain, that's the only tumor that will be bright before contrast, bright on T1 weighted imaging. We know it's melanoma, lytic met. Now, this guy also had a met in the lumbar spine with a pathologic fracture that was compressing the cord. So they took him to surgery for that. I would be curious to see what you would do with this one, if that's a question that would be interesting to you. This guy had no neck pain. He had no symptoms referable to this met up here at all. So asymptomatic, no involvement of the posterior elements, a little bit of epidural disease, no cord compression. Melanoma. Anyone?
I think it's important to talk to the patients here. To the points that have been made, when you calculate this on a SIN score, this is, certainly
not high.
Not high, low, right? But based on the appearance of it, I certainly worry about sort of the long-term structural integrity. So I think you can talk to the patients about the the pros and cons of watching versus surgery, but this is something that would certainly make me quite nervous.
Okay. Anybody else on that one? Looks like Griffin Baum's back.
I'm back. I'm back in action. No, I think some of the immunobiologics, especially the new immunotherapy for melanoma, have been amazing. There have been some cases of brain disease that we've seen that literally just melt away. Cases where we would have had to do pretty radical type of approach. So I'd be interested to see how, how the medical treatment would fare for this. Someone did recommend some radiation, and I think that is a good option as well. But I agree with Coy. I mean, I think, following these patients is really important. There's a big difference between, say, treating someone who, this may be the one opportunity you have before you get lost to follow-up versus somebody who is going to be really reliable, who's going to tell you that they've got severe neck pain or something's changing, they don't know, and then you can follow it up with new imaging. But, I'm not sure, I'm not convinced, but I think certainly if you were going to approach this, I would try and stay away from the occiput. I would see if I could do something like C1 to 3 and stabilize it, because obviously you're not going to get good fixation into C2. And that's how I would approach this.
Nice. Anybody else? So you hit upon a very good point, and I think, I don't remember if it's Jonathan or John said it earlier, or maybe it was at ASR today, the treatment for melanoma, it's amazing how things have changed in how melanoma can be treated now. And this person was on immunotherapy. And I don't want to say too much, but as of now, watching is what's going on. Not surgical yet, but I agree. I would have seen this and I thought, man, why are they not doing something surgically right now? But because the SIN score is low and the patient is asymptomatic from this and they are getting other treatment. So right now it's kind of, well, we'll see. All right. I won't say any more about that. Yeah.
With the advent of immunotherapy, as you mentioned, and checkpoint inhibitors, I mean, it's completely changed the game, in particular for melanoma. I mean, it just like vaporizes the tumor. So in the absence of neck pain or overt instability on imaging, like you said before, I think that's perfect. That's very good for the patient.
Excellent. Okay. Nice.
That's an excellent point. And I have a slide on that actually, that if we have time, I can show you guys, but I think that you're right. I think that with these checkpoint inhibitors and systemic therapies, the challenge is that the patients are living longer, but it's kind of a double-edged sword because they're living longer, but when they present to us with high SIN scores and neurologic deficits, their actual survival is worse, even meeting those criteria. We looked at that, published a paper on that, and I was actually really surprised. And we did that because I noticed that the complications and the mortality after operating on these patients who were receiving these targeted agents was really not great, and it was something so bizarre. And it turned out that that's kind of what happens, is that they're living longer, but there's something about their response to immunotherapy and perhaps their overall frailty that makes postoperative survival worse. So just to kind of reiterate what JR was saying.
Yeah.
Sorry, Wendy.
No, yeah, that's fascinating. I actually learned that from you today at ASNR about how you said they're coming to you later but sicker. And that was very interesting to me. So it's, even though we're making great advances, it's still a conundrum. We're still working on it. Now, I have about 40 slides, and I think we've gotten through 3. But I want to get to John Shin's too at the end. So I'm going to skip through a little bit of this. I just want to show you, for those who didn't know what the SIN score was, as we said, 5 radiologic components, 1 clinical component. This was published in the orthopedic surgery literature in 2010. And
hey, Wendy.
Yes.
Let me guess, you just biopsied that one too.
I already know what it is. I don't even need to biopsy that one. So this was actually breast cancer. And because we triaged them with SINs, they had a high SIN score, and I got into surgery, they regained their neurologic function because we triaged them quickly with the SIN score. Anyway, surgery and all the spine oncology team started using this right away. It's been a little bit slower in radiology. But like we said before, 5 components of this come from our imaging, and then the other one is the mechanical back pain. But validated, excellent interreader reliability. Everybody can read these studies, the MRIs and CTs. And then I showed you that. Let me just quickly go through them. I'm not going to say too much about these. The second category was alignment. Is there already French subluxation translation, in which case that's already unstable, that gets 4 points. New kyphosis, like this case, which was, I think this one was colon cancer, so that got 2, or is alignment preserved? And I'm not going to say this, I'll save this for another day. What do you do with compression fractures in patients with cancer? Because is it cancer or is it osteoporosis? So we'll move on. What is it? Is it lytic or blastic? We know that all METs are actually a combination of both. It's which process is predominating, what's inhibiting the osteoclast versus the osteoblast, but that makes a difference. Things will collapse and cause osseous canal stenosis with pathologic fractures more quickly. If they're lytic, that gets a higher number of points than blastic, which gets none. And this is, I'm going to skip through these quickly. This is prostate cancer, very typical look of a blastic metastasis, dense on this coronal CT, multiple bodies involved. Important thing on MRI, just like cement. So when you're looking at an MRI, what you're seeing that makes the brightness or darkness is moving protons. That's what we're measuring. So if you have a rock or cement, you have no protons, and so it's going to be dark on everything. Same thing with a blastic metastasis, pretty close. It's going to be dark on T1. It's going to be dark on T2. It might not even enhance. So those are much harder to diagnose, and you might need a bone scan or a PET. I won't do that one right now. I'll skip. We'll have to do this another day. So for the SIN score, I love this slide because you have to decide if it's lytic or blastic to give it a score. And this one came into the ER, and I always tell people, you know, I defy anybody to find a met there, let alone tell me if it's lytic or blastic. But on the MRI, you can see clearly there is a met right here in L2. T1 hypointense, STIR hyperintense, enhancing. And so, and here on the axials, there's paraspinal disease, a little bit of epidural disease. And I say just, I guess, call that one mixed, give it a 1, because we can't really tell. Posterior element involvement, important for the pedicles and lumbar spine, the costovertebral joints in the thoracic spine, which are actually those stabilizers that give you extra stability when the body starts to collapse. How much of the body is involved? Mechanical back pain, which we already talked about. So this is how we go through these and go through this SIN score to give people the score. I'm going to skip through the machine learning. JR promised everybody machine learning, and maybe we'll do that another day, but we know another speaker's going to talk about that in a few weeks. And John Shin, John Shin has something more interesting at the end to say. I want to get to that. He's going to say something about it, actually. But the one thing I want to say, though, in the other part of the equation, you care about cord compression. Is it osseous? Is it from a pathologic fracture compressing the cord with bone? Or is it epidural extension of disease compressing the cord with soft tissue? So that the bone part is addressed with SINs partly, and the epidural part is addressed with the epidural spinal cord compression scale. Now, this was the other case I showed on Twitter. This was the metastatic anaplastic breast angiosarcoma. Very unusual tumor. The SIN score is not going to be high, as you can see, because it's involved, but there's no loss of alignment, there's no loss of height, posterior elements are involved. But the epidural disease here is the problem. And this was such an unusual case because it has these loculations that are subdural. They're epidural and subdural. So it's like, what do you do with that? These things are compressing the cord. And Coy said he's going to go in and surgically resect those subdural tumor deposits. This one, I don't know if we want to discuss it. This one probably is a little bit too hard. But my point in my talk to radiologists is, how do you describe this? And this is kind of what I gave Coy a hard time about in the beginning. Cord compression, mild, moderate, severe. What do you want us to call this? Or just call it cord compression? So we have an epidural spinal cord compression scale published the same time as the SIN score. And it's a 6-point scale for radiation and surgery, so that we're all saying the same thing in our radiology reports that you are saying, hopefully, in surgery as well. And the reason for this, can I talk about this, John? Can I talk quickly about separation surgery? Do I have time?
Oh yeah, go for it. Go for it.
Okay. The reason this is important is because, okay, so we have all these different cases here of different types of cord compression. And it matters whether it's mild, moderate, or severe, because when we're trying to decide whether to get surgery first or radiation first, we need to know how much cord compression there is. So before, when we just had conventional external beam, we had to keep our doses low because we're also radiating the bowel, the spinal cord, and everything else. It didn't matter as much, but now that we've got stereotactic body radiotherapy, stereotactic radiosurgery, all these conformal beams, high dose ablative doses going to the MET, things have changed in how we treat these. So you have a case like this, renal cell carcinoma, multiple bodies involved. This one down here is obviously the most important one. Sagittal T2, we've got the MET coming out into the canal, compressing the cord. This is the axial T2. You see the epidural disease compressing the cord. Now, most tumors go to radiation first. Now, if they're stable, this is stable actually. So, but if you radiate this, you're going to radiate the cord, right? So we can't do that. This is a typical horseshoe-shaped radiation plan right here, where you're actually sparing the spinal cord and getting the MET in the bone. But if you have a MET like this, Obviously, if you put on a horseshoe-shaped plan, you're not addressing the epidural disease and you've done no good. So that brings in the concept of separation surgery, which you all know about, but radiologists did not. So what you do is this minimal surgery, you take out the tumor that's in the epidural space, leave the rest, just a minor surgery, and then address the rest with radiation therapy. And I hope John will talk more about this as soon as I'm done talking, because I want to see if I'm saying this correctly. That's why we need the epidural spinal cord compression scale though. So low grade is in the it's either in the bone or epidural space, but not compressing the cord, versus high grade 2 and 3, where it's in the epidural space, compressing the cord, or completely obliterating the CSF, compressing the cord. These two, grade 2 and 3, the high grade, need separation surgery before they can get radiation. Any epidural disease here that's just in the epidural space without cord compression can get radiation first and don't need the separation surgery. Now, before I go on, John, do you have anything to add to that?
No, I think that's a great pictorial representation of that, you know, and I think that.
Thank you, I made that.
I may need to borrow that at one point. That's great. No, I think that I think that one of the main points that comes across tonight is just seeing kind of everyone use the same language. I think it's great because it really creates a dialogue. And you're right. I think when I read a radiology report saying there's no spinal cord compression, but then I look at it, I'm like, yeah, there is. There's like grade 2 cord compression, you know, and then that may generate, though that may lead to an oncologist thinking, oh, there's no cord compression, so let's just radiate it, right? And then we get the call later when all things kind of fall apart. But so I think that's why it's important. And that's why I think like it's really, I was telling Wendy before when I first saw her give a talk and saw that she was quantifying things and using the same language that we often do. We take it for granted, but I think that across different disciplines, there is a knowledge gap. And so I think seeing that and reinforcing that, I think it really benefits the patient.
Always clapping. He likes what you have to say. All right, let's see what we've got. So here are just some pictures. Let's see. We have 10 minutes, so I'm going to go fast so John Shin can show his parts at the end here. So low-grade melanoma confined to the bone. You grade this in radiology on the level of greatest compression on your axial T2. And actually, this is made by orthopedic surgeons. This is from their literature, so they decided that. Breast cancer, there's a little bit in the epidural space, but not compressing the cord. This is 1A. Renal cell carcinoma, epidural space, deforming the thecal sac, but not contacting the cord, 1B. This is a case I showed you. Here you have a little bit of CSF left behind the cord, so that's a high grade, but grade 2. All right, and I won't show you this, but well, I'll just say this real quick. So this one, this is a mess, and this is what I have to look at. So I hope you guys don't like looking at it either, because I didn't like looking at it. But this huge renal cell carcinoma causing grade 3 cord compression, tumor coming out, compressing the cord. They got a separation surgery first, and then to clean out that epidural disease, did not address anything in the bone. They sent them to me to do a radiation planning myelogram. And this was before we didn't have the nice screws, the carbon fiber screws that you can see through. So ours was primarily with MR and myelography. And then after that, they addressed the rest of the bone disease with radiation. So this was the nice cleaning out of the canal of that epidural disease on the bottom. This is the post-op appearance right here. And then they went on to radiation. So that's, again, our multidisciplinary approach, what everybody is doing on the team to address these metastatic patients. And this is where we got to the NOMS, Jonathan Rizzulli. So 4 aspects of disease. So neurologic, which is core compression, nerve root compression. Oncologic, what is the histology of the tumor? What is its radiosensitivity? Mechanical stability and systemic status. And all 4 of those things go into the decision making, whether they're getting radiation, surgery, what order, medical management, something else. And 50% of the data comes from the radiology imaging and from our reports. And that's what I emphasize in my talks to the radiologists. And this is my little diagram of what NOMS looks like that I made. But again, it's this algorithmic approach addressing the answers to each of those questions. So now I'm going to stop. I want John Shin to give his part now. So let me stop sharing my screen, if I can. There. All right, John Shin.
Okay,
that was a whirlwind tour, man. I went fast.
No, hey, that's how we do. We hit it hard. So
we have some good cases, but that's okay.
Yeah, so like I have a couple slides that I'll just show. We are going to do this, I mean, in a different format on Thursday with Majid Khan. So I'm going to go through some things, and if people have to leave at 6, feel free to leave, but I'll just keep talking, even if it's just me talking to myself. So hopefully this will be helpful, and if it stirs up some discussion on the chat, great. So I'm going to share my screen. All right, you guys can see what I have here. Good. All right. So I think Wendy, she does a really awesome job at really highlighting the sort of the mechanical aspects and the degree of epidural spinal cord compression, the radiographic aspects of that. But I think that one of the hardest things that we do is really assessing the impact of the S in NOMS. And like all of you know, NOMS is not a predictive model. It's just really a conceptual framework that Mark Bilski really pioneered and came up with, his idea. So it's just sort of a template for us to think about these things. But the challenge that we have is really, can we quantify that S, and how do we use that in our decision making? So as Wendy said, as surgeons, I like to think of myself as kind of like a caveman surgeon. We kind of tear things apart, we put screws into bone, and we feel pretty good about ourselves at the end of the day, but we're pretty good about neurology, right? Whether you're a PGY 1, 2, 3, or 12, you can figure out if someone's weak in a leg, arm, foot. We can understand the radiosensitivity of these cancers. And we're now with SINs, as Wendy pointed out, we're really good at assessing the mechanical instability. Even before SINs, if we look at an MRI or a CAT scan, you'd think, ooh, that looks pretty bad, probably needs surgery. But now with SINs, we have a tool to really talk and think about that. But what we really struggle with is, can we predict the survival, complications, and even the benefit of surgery? And even if they meet all these criteria, how do you quantify that at the bedside and make that decision? And, I think, we've always talked about this in spine meds, and I think you have to really come back to this. What are the goals for this patient? We think about the neurology function, the stability, but ultimately, we're also concerned about the local tumor control. And that's where the radiosurgery comes into play. We think about the pain, their quality of life. And, we see things like this, right? Prognostic, modeling, and this is from the Sloan group. You can see this in a number of their publications. And again, there's the N, the O, the M, and S, a lot of arrows going this way and that way. But if you look down here for systemic, it's really like, what do you make of this, right? Are they able to tolerate surgery, unable to tolerate it? When one of my residents on call, they called me last night, said, hey, we've got this patient. And I asked him, what do you think? I was like, well, I don't think they can tolerate surgery. Okay. That's their hunch, right? But can we take it beyond what that hunch is? Because you can see this does factor into the decision-making for what goes on up here. This is just a chart. I'm just going to put a shameless plug. We have a paper coming out this Friday in JNS on RCC survival and looking at various prediction models. And so we studied a number of these predictive tools. And you can see here, there's Tokuhashi, Katagiri, the Sorg nomogram, the New England score, Bauer, modified Tokuhashi. And you can see the parameters that are here, what they use to calculate these. And so whatever you pick, you can see that there are so many different ways to try to prognosticate the survival for these patients. And they're not perfect. Some are better than others. Some of our more recent machine learning type algorithms definitely have promise and need to be externally validated. But there is now, with use of advanced statistics and larger data sets, we can do things like that. But historically, things that are still commonly used, like the Tokuhashi, which a number of people in the chat box have referred to today, are not so accurate when you look at specific cancers. And that's why, I'm just going to point out to the paper that is going to come out this Friday. We looked at RCC metastases specifically and showed sort of how each of these different scores measured up with actual survival data. So here's a patient with RCC, just like a lot of the scans that Wendy showed before, comes in with 3 months of back pain, not able to stand, ambulate, legs are strong. And let's say the PET and the MRI shows that this is the only lesion here, okay? And I think you can pretty much tell that there's cord compression, a lot of flow voids, squiggly lines in there, right? So I think that, you know, this patient has one lesion, right? But if that person comes in now, same age, but no cancer history, comes in with a large kidney mass, a lot of back pain, same exam, but maybe one spine lesion, but diffuse metastases, liver, lung, and in the brain, you know, would you treat that patient the same way? Okay. And I think that's what we struggle with. Go through the SIN score. That's a SIN's of 10. But as I think JR mentioned before, renal cell has changed a lot. You can PubMed it, New England Journal, Lancet. There are all these drugs, medications that honestly, as surgeons, we have no idea what the hell they do, you know? And it's not in our training. But I think that what we see though is that historically over time, and there's so many of these, I just keep pressing my animation thing, it keeps going. You can see that over time, that survival in 2005 was about 13 months for patients with metastatic renal cell carcinoma. In 2015 is about 25 months, okay? Larry Rines and his group at MD Anderson, they looked at this previously, published in JANUS Spine. It's the largest cohort of renal cell metastases, and they showed that their survival after spine surgery was 11 months, okay? But this predated immunotherapy and molecular therapy, okay? Large retrospective series, MD Anderson, okay? A lot of really experienced neurosurgeons on this, Larry and Azia on this paper. So we looked at our data set at MGH, looking at about 90 patients, very similar, but we looked at the cohort essentially all now in the era of immunotherapy and targeted therapy. And it's a little bit busy here, and this is going to come out in neurosurgery pretty soon, but we were able to show that the patient's survival went from about 222 days to 913 days when starting these new adjuvant therapies after surgery. And you can see that even with a KPS less than 80, those patients who started adjuvant therapies for targeted therapies after surgery, their survival was even longer. So we know that KPS above 80, those patients tend to do well anyway. But when we looked at those patients who didn't have great function before, when they started therapy, they did have longer survival. And this patient underwent embolization. You can see here, this is what it looked pre-embo. Our team likes to use coils, looked great, still bled a lot. So I went into that operation thinking it was going to be a separation surgery, like Wendy pointed out in that awesome graphic, maybe, you know, cut away that posterior third of that vertebral body wall, take down the PLL, circumferential decompression. But as you know, this thing bleeds like crazy. So once we got in there, it just bled like crazy. So I ended up just taking it out, reconstructing it. Similar case, melanoma, metastatic, a lot of metastases, 2 months on immunotherapy, BRAF positive. Again, for the non-oncologist, that's just like science fiction. It's like, you don't know what to think of that, but believe me, it's an important molecular marker. This patient comes in clearly debilitated, right? They've got a neurologic problem, radiculopathy, unstable spine, anterior involvement, posterior involvement. We can calculate it. Okay, so it's intermediate, between 7 to 12, okay? But with melanoma, same thing. I'm gonna keep clicking, got all these New England Journal articles, and same thing. With all these agents now, the survival is longer. Now for melanoma, it was pretty bad to begin with. 3 months survival, right, with metastatic disease, but now it's longer, almost a year. And this is a study that I was referring to later that I think someone mentioned in the chat box. We looked at these patients because these patients were presenting to us with a neurologic deficit, cauda, spinal cord compression, mediate to high SIN score, and with a relatively radio-resistant tumor. And with those criteria, thinking that those patients would do well, we noticed that those patients who had been treated on immunotherapy, their survival, as you can see here, was much worse. Okay, doesn't mean that we don't operate on these these patients, but it gives us a different discussion point when we're talking about the risk of surgery and thinking about survival. I know I'm kind of blasting through this, so if anyone has questions, please just interrupt. But I want to kind of get through it. So if anyone has questions, we can kind of talk about it. This is all based on retrospective data. Okay, so this is MGH data retrospective. The MD Anderson data is retrospective. But how do we make it better? So now, as part of the AO Spine Tumor Forum, which I'm a part of, a lot of people are a part of, we're doing this prospectively, and we're taking not only their surgical data, but their medical data, their laboratory data, their patient-reported outcome data, their pain scores, response to treatment, systemic therapy treatment, doing this in multiple centers around the world, prospectively recording the data with very specific study questions in mind so that we can analyze and maybe change the, or at least change the paradigm in terms of how we think about these things with prospective data, and then use that in machine learning algorithms. So again, we think about how are we going to determine if that patient's fit for surgery? Well, now it comes down to the molecular markers as well as the frailty. And now in the lab, we're taking bone marrow from the vertebrae that's distant from the tumor. We're taking it from the actual tumor site, taking that to the lab, doing single cell analysis and really looking at the subset of those cells, creating different animal models for bone metastases to see are there any targets here that we can change or alter in the bone marrow that can work with radiation or systemic therapy. So it's not just about looking at the patient and thinking that they can't tolerate surgery, whatever that means, but really trying to get granular and coming and trying to stratify that based on different characteristics, including molecular analysis. And this goes into the last point I think JR mentioned. So with my colleagues at MGH, Joe Schwab and other colleagues, really been interested in looking at predictive analytics using machine learning tools to create predictive models for predicting survival as well as complications. And this is just an example of the nomogram that was developed using national databases. And you can find the publication and plug in different parameters and to play around with it. And these were publications looking specifically at survival. I'm going to show you, when we continue to refine this, this is our working calculator that we're in the process of refining. And just to show you in real time, we're developing a model looking at predictors of 30-day complications. And we can do things like click in real time, their age, their BMI, they have COPD, do they smoke, use steroids, what type of surgery, what their preoperative white blood cell count is, their albumin, and come up with a prediction score using these analytics to provide some counseling. So it's not perfect, but that's sort of where we're going. And the goal is to really take that S and to make it more useful, not only for the surgeon, but also for talking to patients. And so just to wrap up, I think that where we're going with this is that we have to have a better understanding of their frailty, their sarcopenia, their overall condition, nutrition, molecular markers, sort of feeding into survival. So I just wanted to mention that because I know that Wende did a great job talking about sort of the radiographic appearance and the implications of that. But I thought that this would help sort of flesh out for the audience, how we put that all together in these multidisciplinary discussions. So that's what I have. I'll leave it for any questions or objections. I'll stay on for a couple minutes, so.
That was fantastic. Thanks, Sean. We both had to go through, I think we both had much more material we could have gone through, and so maybe we'll have to do it another time. Jonathan, do you see any last questions to ask before we wrap it up? Or
I'm just going to say two things that popped to my mind. Those are awesome. That was awesome, John. Thank you so much for that. For the residents and the med students, I can't stress enough how awesome and how educational it is if the hospital you're at has a tumor board for you to go to that and just see how just all the people, all the different disciplines, all the the radiation oncologist, the surgeon, the oncologist, everybody kind of talking about these cases and how systematic they are and the workup that goes into them, all the imaging, all the discussions that go into this. It's so invaluable to your education. When you're in residency, very frequently, the way that you see these patients is unfortunately in an emergency. I think 80% of the spinal mets I've seen has always been, Friday night emergency room call or a patient on the medicine service, which gets rushed category 1 into the OR, doing decompression, 2 up, 2 down. That tends to be the vast majority of what you'll see. But as you can see, there's so much more that goes into this, and this is something that really requires many different inputs from different services, and it's just great to see this. When this is done well, as Dr. Shin has showed us, it really makes a tremendous impact in the prognosis of the patient.
Griffin, before you ask your question, I just want to make one follow-up comment to what Razuli just said. I agree with that, and I was telling John before we started, we each learn our own specialty, whether it's radiology, radiation oncology, or surgery. And the reason I started being interested in this is because when I started 5 years ago at my first job, I wanted to be part of the tumor board. And so I read everything I could about spine metastases from the perspective of surgery and radiation oncology and oncology. And that's how I found out that we had stuff we had no idea about in radiology. And I found out from giving this talk everywhere that no radiologists know this stuff. So going to your tumor board is where you find out this stuff that everybody else is doing, but we all need to work together for the patients. So it is very valuable to hear all the different perspectives. So thank you. Jonathan said that much more eloquently than I just did, but I wanted to say that I agree with that. So now, Griffin Baum, your question.
So John, your resident called you last night when you were on call and said, Dr. Shin, I just don't know. I don't know if this patient's gonna be able to handle surgery. How do you judge it? Middle of the night, patient getting called, trying to come up with a plan. What are the just couple factors, or maybe the 30-second line for some of us as we deal with those consults in the middle of the night?
Yeah, I think that it's really hard to gauge because I've been burned both ways, right? So, I've been on the phone call, I've been on the phone, and by the way, we have great residents, so I'm not ragging on the residents, but, they'll say, oh, they've got this, they've got EC, grade 3, whatever, SIN score. I'm like, okay, just pre-op them and get ready for the morning, and I'll come by first thing and talk to them, and then I see them, I'm like, oh, there's no way we're operating on this person, So I think that it's hard. I think that the thing that I try to, I'm not calculating like Tokuhashi and, we've developed some of these algorithms, and to be fair, when you have the time to go through it, it's a really great exercise, but ultimately there are some things that really tend to predict their survival. I think these markers of like nutrition and like a really low albumin, the extent of their visceral metastases, their failure to improve on several lines of systemic treatment. I think those are all real indicators that, this person may be really at the window where they may not survive, past 3 months, and even that 3-month time period is a little bit of surgical oncological dogma. We're constantly questioning, like, where did that come up with, that 3-month mark? But I think those are the rough estimates. We like to sort of get a sense of what's the extent of their systemic metastases. Are they symptomatic? What's their albumin? Because that could be a good indicator for their overall nutrition and frailty. But you're right, it is very difficult to assess that overnight. Luckily, there aren't too many situations where we're rushing in the middle of the night to do these operations. But I think that it just speaks to the challenge, wherever you are. You could be in a busy academic center, or you could be at a community hospital. We all face the same challenges of trying to make the right decisions.
Yeah. Well, John, that was a great talk. And Dr. Amagani just actually posted, I think, a great concluding line, which is, in his experience, he always has to see the patient on his own. And I think you just said that too. And I can tell you, I'm on call this week, same situation. It really goes to speak to the value of seeing the patient, examining them on your own, and coming up with the plan. So thanks again. That was a great talk, guys.
No, absolutely. And I think that it's hard because, everyone comes to the table with their biases, right? And I think that another sort of talk that I give a lot is like how to develop a multidisciplinary program at a hospital. And, maybe, for for guys starting out or just starting, or maybe they don't have that at your hospital, it's hard to get a lot of people to the table, right? Because I will tell you very openly, interventional radiologists, whether it's neuroradiologists or MSK, they sometimes may be threatened where there's like a surgeon that wants to now, take care of all these cases, right? Or, if you're a surgeon and you're doing kyphoplasties, when I was a fellow at the Cleveland Clinic, we did a lot of kyphoplasties. And JR, you could probably, I don't know if you still do, but I just remember thinking, wait a second, this is a radiology procedure. Like, why are we doing so many kyphoplasties, right? And then I got to MGH, and I wasn't trying to do kyphoplasties, but I did several. But then I would kind of like look behind my shoulder. I'm like, we've got one of the world experts in kyphoplasty and augmentation at this hospital. Like, why am I doing that? There's just like no need to do it. And I think that, that's like the one consideration. You just have to, that's why I really stress like trying to get a team together and build that sort of dialogue, and to take away that fear that you're trying to take over someone's like, domain. I think that's really important because there are so many areas where there's overlap, but I think if you look at it as a benefit, there's really awesome synergy that can happen.